So the main debate about the varicocele will be focused in the best technique, because until now, for varicocele, about the theology, history, and everything, I think everybody knows very well that. But it's not very clear still which is the best technique or which should be the best way to treat these patients, because we don't know even if it's really necessary to treat varicocele. That's the main question. So everybody's operating, but we don't know if really we're doing the best thing or not. So the main thing that we think when we have an adolescent with a varicocele is that we are very worried about the fertility and the testicular hypertrophy. But testicular hypertrophy also is something that we need to evaluate, especially in a 12, 13, 4-year-old boy where the testicles are growing. And most of the time testicles are growing asymmetrically. There is one testicle that grows faster than the other. And when I see my patients every year, I always find that the testicles are switching. So the testicular hypertrophy, to get a right diagnosis, we need to wait until this patient has almost finishing their development. The pathophysiology, we know especially that the dilatation of the veins increase blood flow increase temperature, and temperature will cause apoptosis for the spermatogonia. But notice only that. We know that also the renal adrenal metabolites reflux into the dilated spermatic veins, the low oxygen concentration in dilated veins with local tissue hypoxia, and the paracrine imbalance. But we are trying to treat adolescents to avoid a complication in the adult life. But we need to know, first of all, what our colleagues or adult urologists are doing with adults with varicoceles. So the recommendation for the American Urological Association says that the majority of men with varicocele are asymptomatic and fertile. So the main recommendation to operate a varicocele is if a couple attempts to procreate, the female has a normal fertility and the male has a varicocele with abnormal sperm parameters or sperm function test. And then they treat, they operate, and they have seen that there is almost a 60% of seminal improvement after this treatment. What are we doing with adolescents? Why is so controversial the treatment? Because first of all, the results of the treatment are not clear. And only 10 to 50% of these adolescents will present the varicocele. And there are some studies that say that 70% of the varicoceles could present a regression during adolescence. So, what is the rationale for the therapy? That the varicocele could be progressive? Yeah, we assume that. And maybe that early repair would prevent infertility. So, these are suppositions that we are trying to avoid a risk in adult life. So, what is the real indication that we use then? Because I can imagine that in different centers, we have different parameters and different rules. We can talk about the bilateral varicocele at the end of the stage of testicular development. We can talk about testicular hypertrophy, which means should be less than 20% of volume in comparison with the other testicle. There are some index also for measure, but we need to be sure that this boy is almost finishing the testicular development. Discomfort and pain, sometimes, most of the patients that I see with varicocele, even if it's a big degree of varicocele, they say that they don't feel anything, but they are not disturbed. A grade 3 varicocele, according with the Amelor classification, or the psychological repercussion. So these are the main type of indications that I have found. So which one is the best treatment? And that's where we decide to organize this debate. And I'm going to concentrate in the laparoscopic one. Laparoscopic varicocelectomy, which is the technique that we decide to perform in our institution. So there is this very nice publication from 2010 from the team of Chiro Esposito, where they analyzed the main publications in the literature regarding the therapy, either laparoscopically or open, to see the difference and the advantages. So they found 11 studies between 2000 and 2009. They found 5 multicentric studies, 4 randomized trials, 2 clinical trials, total of 1,443 children from 6 to 70 years. And the main results were that there were no significant difference between laparoscopic varicocelectomy versus open regarding post-op hydrocele, which was around 9.5%. There are series that talk about even 15%. But there is a lower rate of hydrocele in patients undergoing dye injection before surgery, which is something that we're going to discuss after with Fabio. There are no significant difference between recurrence regarding open or laparoscopic, which both have an index around 4.7%. There is a significant difference in recurrence when we are doing the laparoscopic Palomo versus the laparoscopic modified Palomo, which is trying to spare the artery. When we spare the artery, we increase the risk of recidiving, of recurrence. So we did a retrospective study in our institution, and then we joined also with the team of Lausanne, analyzing all the results for patients that were operated for laparoscopic varicocelectomy. And we found 81 patients. Age was 10 to 17 years. Most of the cases were a left varicocelectomy. We performed an abdominal and testicular ultrasonography, Doppler. The main indication for Doppler was measuring the vessels, because we talk about measures of more than 2 or 3 millimeters in diameter. There are classifications for reflux also from the radiological point of view or sonographical point of view. But what I'm interested in is in the testicular volume, and if there are some calcifications or some other things that could be involved in the testicle. Something that we do also is always look for the left kidney, especially when we have very young patients with a premature varicocele. We include also 1 recurrence after an inguinal open varicocelectomy. So, regarding the classification of Dubin and Amelar, we have 64 patients with a grade 3, 11 grade 2, and 5 patients with this between 2 and 3. 32 patients had clinical testicular asymmetry, 4 with a second degree, and 19 with a third degree. We operate 74 patients with a transperitoneal approach using conventional laparoscopy, 3 trocars, with instruments of 3 or 5 millimeters, depending on the age of the patient. And then we start to move to the seals. So the last 7 patients were operated with a seals with 3 and 5 millimeters. We performed 68 Palomo and 13 modified Palomo. The modified Palomo were performed mainly in Lausanne. We used ligatures at the beginning in 34 patients, but now we're moving to clips. So most of the clips are in the last years. 48 patients are treated now ambulatory in the day hospital, and at the beginning we used to keep them for 24 hours of recovery. The follow-up goes up to 7 years. Our results are that we don't have any postoperative atrophy, even with the Palomo technique. We found that there was a recovery of testicular asymmetry in 18 out of 23 patients. We don't know if it was just testicular development. And what is very interesting is that I found in the literature that even with the Palomo technique, the rate of testicular atrophy is not as high as we thought. Most of the studies talk about 0 to 2%. Oops. No genitofemoral nerve injury was recorded, even if there are some publications that go up to 70%. No postoperative infection, no incisional hernia. Aesthetics were very good. So we have a recurrence. 2 patients out of the 13 patients with the modified Palomo have a recurrence, and they were operated again laparoscopically with a Palomo, and they are doing now good. The recurrence for most of the laparoscopic varicocelectomies in the literature goes to 6 to 15%. Hydrocele, this was our main problem. Because at the beginning we have 11 patients, 9 from the Palomo, 2 from the modified Palomo. And out of these patients, 7 didn't need any therapy because it was a small or low hydrocele, but 4, it was necessary to operate them. What the literature says, post-operative hydrocele is reported in very high still, 27 to 50% with the laparoscopic, just with the laparoscopic. We have 8 years ago a complication, a serious complication. Patient that we operated, it was operated, and we performed the normal Palomo. We put ties, ligatures, and then we cut the vessels, and we keep it in surveillance, and then he started bleeding. We took him to the OR, and fortunately we solved the problem. But since that we have this experience, we start to keep 24 hours of surveillance, all patients with varicocele. That's why there were some that were recovered for 24 hours. When we switch to clips, we change also this attitude. So, since 2011, we decided to modify a little bit our technique. And we decided just to make a very high dissection and just clipping. We present our results of varicoceles in the IPEC, I think was in 2011, I think was in Dallas, I can't remember very well. But talking with some colleagues, they say that they started doing just clipping, not section, nothing else, just put clipping and a very high dissection. So we decided to move also. The other thing that we start to do is we start to decrease our indication for surgery. And that's why we have a very few or lower amount of patients. So we have 30 patients since 2011 with this technique, and we perform only from this half of the patients with the SEALS technique. I will show you how. It's a very fast procedure, and since then, it's true that it's very few. We have very, very few patients, but we haven't had any hydrocele. No recurrence, no atrophy, no other complications, and until 3 years, everything is going good. But this is a very, very few amount of patients. So this is the setup that we use for a regular laparoscopy, but now we're moving to SEALS. What we're doing with SEALS? First of all, you know very well, most all of you know very well the SEALS, but to put this device in the abdominal cavity, you need to make a 2.5 centimeters of incision in the umbilicus. And this is too big sometimes. So I was trying to see with Covidian if there was something that we can do to modify this device. So I decided to modify. I took out all the implements, and then I cut it. I section right where the 3 holes, the near holes are, and then I insert the troppers, and I suture. And I'm reducing the size of the seals from 2 centimeters to 1 centimeter. And this allows to get 2 5s and 1 3. One instrument of 3 that doesn't need a tropper. I was afraid at the beginning that doing that I will be in risk to losing pieces of the seals. But the material is very, very stable, and it holds very well. And I invite you to try to cut one seals and try to get pieces out of it. It's very difficult. It's very stable. It's a very stable material. So I start to do that. I reduce to the half the diameter of the seals. I perform a transumbilical incision. I perform just 1 centimeter or 1.5 centimeters of a dissection. We introduce the seal, the device, and it works very good. The main thing is the tricky instruments that we have to use as the surgeons that perform this type of surgery know that this type of instruments, like in robotic surgery, are very, very important if we want to do the things in a good way. So, dissection is very important thanks to the bending of these instruments. So, what we do is just, we go very high, we open the peritoneum, we make the dissection. Oops. Can you run this video, please? The dissection is very easy with this bending Marylander dissector. And then, can you run the video, please? You apply the clips, 4 or 5 clips, and that's it. We don't do anything, and then we move out. And as you can see, we remain very, very, very high. and distant from the internal inguinal ring. We remove the device, we close the suture, and these are the results, aesthetical results. So patients are very, very happy because at the beginning when I started to use the seals, all my patients had a halo, a red halo, and sometimes they stay for 2 or 3 months without halo. Since I begin to decrease the diameter, we don't have this problem. So, why seals? Because yesterday was a discussion about if it's really necessary or not, if it's worth it or not. I'd say, for me, in this type of technique, in this type of procedure, it's a peristhetics because it's 1 incision instead of 3. It reduces the diameter from 2.5 to 1.5. It's a very fast procedure. It's a single incision with no air leaking. When we are doing just single incision and going with the instruments directly, we have a big problem always with leaking. With this device, we don't have that problem. It allows 1 telescope of 5, 1 instrument of 5, which could be the flexible dissector and then the clip applier, and then 1 3mm instrument, which is the traumatic grasper. And we are taking all patients now in a day hospital surgery, which decreases a lot the cost for the hospital. Because with the DRG, when we have patients for 1 night, we lose a lot of money. So using the device and having the patient in an ambulatory way, the insurance will take care of all expenses and justify. The only problem that I see is that it's a tricky technique, just because when you are working with bending instruments, you know that if you're going to dissect from the right side, you're working with your left hand. Conclusion, the laparoscopic transperitoneal approach allows a great exposure for dilated spermatic vessels. Laparoscopic Palomo technique represents a minimal risk for postoperative testicular atrophy. The risk for postoperative varicocele is possible with both techniques, but seems that the technique of high dissection and just clipping reduces the risk. We need to prove that first. We need more patients. The laparoscopic modified Palomo technique has a higher risk of recurrence. And our results confirm that the laparoscopic varicocelectomy in teenagers is a feasible, safe, and good option.
Okay. Thank you. Thank you, Mario.